Learning with L&R. Dear aspirants, you're welcome on Learning with L&R, and today we are going to discuss about the new topic, that is nephrotic syndrome. This topic related to urinary system and related to children. The definition of nephrotic syndrome: it is a primary glomerular disease characterized by proteinuria, hypoproteinemia, edema, and hypercholesterolemia, hypoalbuminemia, hyperlipidemia. Because of gross proteinuria, serum albumin is low, less than 2.5 gram per gl. What is glomerular disease? It is a disease which alters the normal function of the kidney. Okay, proteinuria means protein present in the urine. Hypoproteinemia, the protein level in the blood reduced, edema, swelling are there. Hypercholesterolemia, the cholesterol level high in the blood. Hypoalbuminemia, the albumin level low in the blood. And hyperlipidemia, lipid high in the blood. Okay, then the types of nephrotic syndrome. Idiopathic nephrotic syndrome in childhood, the vast majority belongs to category. It is regarded as a sort of autoimmune phenomenon, especially since it responds well to immunosuppressive therapy. It is two types: minimal change nephrotic syndrome, this predominant type, seen 86% of the cases, and significant change nephrotic syndrome, this is infrequent. Mesangial proliferation is seen in 5% cases and focal sclerosis in 10% of cases. Then secondary nephrotic syndrome, it occurs in children about 10% of all cases. This condition may occur due to some form of chronic glomerulonephritis or due to diabetes mellitus or systemic lupus erythematosus, malaria, malignant hypertension, hepatitis B, infective endocarditis, inflammation of the endocardium, HIV/AIDS, drug toxicity, lymphomas, syphilis, etc. And congenital nephrotic syndrome, it is rare but a serious and fatal problem, usually associated with other congenital anomalies of kidney. It is inherited as autosomal recessive disease. Severe renal insufficiency and urinary infections along with this condition result in poor prognosis. Infantile nephrotic syndrome, the term is applied to nephrotic syndrome occurring in infants between 4 to 12 months of age. Its major causes are NFHS 2 and diffuse mesangial sclerosis. Etiology of nephrotic syndrome: primary renal cause, minimal change nephropathy, glomerulosclerosis, acute post-streptococcal and glomerulonephritis, immune complex glomerulonephritis. These all conditions cause the alteration in the normal functioning of the kidney. The function of the kidney to remove the toxins from the blood, from the body, with the help to flush out the toxins. But because of these kind of things, these kind of problems, the normal functions kidney do not capable to do, right? Then systemic cause: infections, toxins, allergic, cardiovascular malignancies, and other diseases like systemic lupus erythematosus and other. Pathophysiology: alteration in glomerular basement membrane, then alteration glomerular protein permeability, it increased loss of protein in urine. Because of that, colloid osmotic pressure decreased. What is the function of colloid osmotic pressure? Colloid osmotic pressure maintained by protein, and the main function of this to maintain the fluid balance in the body, right? When it decreased, colloid osmotic pressure decreased, what happened? Decreased vascular volume, which leads to decreased renal blood flow, which leads to increased secretion of aldosterone. and also it causes edema. When secretion of aldosterone increased, it caused tubular sodium and water reabsorption. Because of that, edema occur. Then clinical manifestation. 4 main symptoms of nephritic syndromes are proteinuria, hypoalbuminemia, hyperlipidemia and edema. Then others are shortness of breath, mild headache, fever, rash, joint pain, weakness, malaise, anorexia, weight gain, periorbital edema, the edema around the eyes, irritability, ascites, hypertension, anemia due to loss of red blood cells, flank pain and fatigue. Diagnosis. Palpation. When we palpate the patient, due to edema, the ascites kidney cannot be palpable. When the ascites are present, there we do not palpate. And urine analysis, hematuria, blood present in the urine, 24-hour urinary total protein estimation, urine sample shows proteinuria less than 3.5 gram per liter per 24 hours. Then blood test, blood urea creatinine, blood urea nitrogen, creatinine, serum protein decreases, lipid profile goes high, that is above 200 mg. Comprehensive metabolic panel shows hypoalbuminemia, albumin level is less than 2.5 gram per dl, needle biopsy of kidney, ECG, X-ray, renal ultrasound, renal scan, then intravenous urogram. Then how we manage this problem? First of all, medical management with the help of medicine. The goal of medical management is reduction of protein excretion. If causative agent is streptococcal, then treated with penicillin antibiotics. The penicillin is the drug of choice are there. Prednisolone is the another drug of choice is there. The prednisolone daily dose of 2 mg per kg per day orally is divided doses for 6 weeks is given. Thereafter 1.5 mg per kg a single dose on alternative days for 6 weeks, after which treatment is discontinued. With the taper of this medicine, prednisolone, that is steroid, discontinued. Fine. First 6 weeks we continuously given to the patient in the divided doses according to the weight. If the patient weight is 6 kg or 10 kg, if the patient weight is 10 kg, then we provide them to 20 mg prednisolone in divided doses, and after that 1.5 mg per kg according to weight of the patient for next 6 weeks on alternative days, and after that we discontinue the treatment. Then proteinuria disappears within the first week of therapy, and the negative dipstick test for 2 consecutive days show positive response to treatment. Frequent replaces are treated by alkylating agents such as cyclophosphamide 2 mg per kg daily for 12 weeks, nitrogen mustard, cyclosporine or levamisole, diuretic and salt poor albumin may be indicated in presence of severe edema. Furosemide may be prescribed. Then dietary management. Children should take a well-balanced diet rich in protein because protein is low in the body. Sodium is restricted because there is a chances of hypertension, and edema is also there. Provide high protein and high carbohydrate diet to patient. If patient is advanced stage, then avoid protein intake because it is affected to kidney. Water restriction may be indicated because there is already edema present. Nursing management. Nursing diagnosis risk for infection related to immunosuppressive drugs, fluid and electrolyte imbalance related to edema, impaired skin integrity related to disease process, altered nutrition related to anorexia, altered kidney function related to disease condition, knowledge deficit related to disease process. Then Care during hospitalization. What kind of care we provide to the patient? We provide care to the child when he admitted in the hospital. Child is hospitalized from initial therapy. Patient may not understand the importance of hospitalization because initially the child is symptomless. Very less symptoms are there. During hospitalization, parents should be involved in child care and goal setting, and they become trained or aware about how to provide care to the patient. Nurses should regularly monitor the vital signs and check the child daily weight. Monitor signs of infection and edema. Detailed charting of intake and output. Detailed charting of intake and output must be done to monitor child's response to medical therapy. Daily urine examination for albumin is required. Then administration the prescribed medications. Children with nephrotic syndrome are receiving steroids. For example, prednisolone in divided doses. So the nurse must be aware of the side effects of these drugs. Patient should be observed for gastrointestinal bleeding, gastrointestinal ulcers, hyperglycemia and cataract. Steroid is continued till the child is protein free. Thereafter, the drug dose is decreased gradually. After that, maintain fluid and electrolyte balance. Nurses should monitor serum sodium level of the child. Fluid intake, either oral or IV, should be strictly monitored. Child is assessed for venous stasis, ascites and pulmonary edema. Daily weight of child is accurately documented. Then prevention of infection. How we prevent the child to become infected? The child is on corticosteroid therapy and there is a loss of immunoglobulin in urine. So these children are the greater risk of infection. Strict aseptic technique should be used during invasive procedures. Monitor vital signs for early signs of infection. Isolate the child as he is on immunosuppressive therapy, that is corticosteroid therapy. Promote rest. Provide passive play to the child as tolerated. For example, watching TV, reading storybooks. Then allow a period of rest after activities. Limit visitors during acute phase of illness so that less disturbance are there. Provide emotional support. Explain parents about the disease and its treatment. Allow the patients and child to express their feelings due to sudden weight gain and disturbed body image. Child may manifest with behavioral changes, may refuse to look at mirror and has decreased interest in appearance. Enhance the body image of the child. Encourage child to wear own clothes so that he or she feel comfortable or feel good. Discharge plan. Explain to patients about treatment program, follow-up and risk of relapse. A patient not able to understand the thing, then this awareness provide to the parents. Encourage patients to measure child's weight weekly. Encourage parents to measure child weight weekly in order to identify early fluid retention. Tell them to contact doctor if any unusual symptoms are there. Increase intake of fruits and vegetables. No potassium and phosphorus restriction is necessary. Explain about the medications to be continued at home and their side effects like Cushingoid appearance, gastrointestinal bleeding and sodium retention. If the child is on corticosteroid therapy for a very long time, fundus checkup should be done because prednisolone causes cataract. Dietary medications should be explained to the parents. Ask them to avoid saturated fats such as butter, cheese, fried foods and fatty cuts of red meat and egg yolks, and increased unsaturated fat intake including olive oil, canola oil, peanut butter and nuts. The child can eat low-fat desserts. Thank you. I hope you have clear with this.